All right, so welcome to Road to 250. Today we'll talk about cranial nerves, cranial nerve lesions, and then I will briefly go over the pupillary light reflex. And then at the end, we have some review questions. So moving right on in. So the brainstem, this is the ventral view of the brainstem. As you can tell, we have a bunch of cranial nerves. But the most important part I want you guys to take out of here is you have 4 cranial nerves that are above the pons, and that's 1, 2, 3, 4. 4 cranial nerves that are in the pons, and that's 5, 6, 7, and 8. And then 4 cranial nerves in the medulla. And then you have 4 cranial nerves that are medial. So these are 3, 4, 6, and 12. So this is basically where they come from inside the skull. And then you can break this down into the anterior cranial fossa, the medial cranial fossa, and the posterior. And as you can tell, we have certain ones, and I'll go over each of them throughout the slides as I do the individual cranial nerves. But this is just like a brief overview, and just the big thing you want to take, that the divisions of cranial nerve 5, the trigeminal nerve, have 3 separate ones. So V1, V2, and V3. And you can use the mnemonic standing root only for superior orbital fissure, rotundum, and ovale. So just keep that in mind. So this is a general overview of what each of these cranial nerves do, their names, if they're sensory, motor, or both. And there's a mnemonic that you can help you remember the sensory or motor. But we'll go over each of them in detail, and then the lesions that can happen for each of them in the next 20-ish slides. So without any questions, we will move right on in. And like I said, the midbrain has the nuclei of 3 and 4. The pons have 5, 6, 7, 8. The way that some people say is like pom-poms, as you're making a cheer, 5, 6, 7, 8. The medulla has 9, 10, 11, and then the spinal cord has the nucleus of the 12th one. So what we're going to cover today are just the functions, how to test the functions of each of these cranial nerves, the results of the lesions, and then where they exit from the skull. So cranial nerve 1, obviously, is your sense of smell. So this is you smelling something like an alcohol wipe. The result of the lesion, you lose the sense of smell, and it comes out of the cuneiform plate of the ethmoid bone. So the damage can be done by trauma, such as a skull fracture, but can rarely also be done by infections or tumors. I should say, or not all. So cranial nerve 2, it's vision. It's going to be a sensory nerve, and the tests that you can do are visual acuity, visual fields, and pupillary reflexes. And if you have a result of a lesion, will be vision problems. And the pathway is basically optic canal of the sphenoid bone. So cranial nerves 1 and 2 are found outside of the brainstem. The rest are in the brainstem. So cranial nerve 3, it's main nerve that moves the eye. So to move the eye up, it uses a superior rectus muscle. To move the eye medially, it's the medial rectus, inferior rectus, and then superior rotation or inferior oblique. So you can also elevate the eye through the levator palpebrae muscle, and there also helps in the pupillary constriction through the sphincter pupillae. And the test you can do is the H test or the pupillary reflex. So a lesion or a result of a lesion will be a cranial nerve 3 palsy, which will be down and out. The eye will be down and out, and then the pupils will be dilated, and there's ptosis. So this comes out of the superior orbital fissure. We'll go through more about this one in the next few slides. So, as I mentioned in the last slide, the eye movements are controlled by various nerves, and certain muscles are controlled by certain nerves. But cranial nerve 3 is the major nerve that controls a lot of your muscles, including your superior rectus, your inferior rectus, your medial rectus, and your inferior oblique. And then obviously it also has these other side jobs that we discussed the previous slide. Here, your lateral rectus will basically have a lateral movement, your superior oblique basically inward and downwards movement, and medial is medial towards the nose. And then this is the inward and upward movement. So the blue ones are all your cranial nerve 3. The red ones, is your cranial nerve 4, your trochlear nerve, which we'll talk about. And then the green is your abducens nerve, which just does one muscle. So the mnemonic that many use are LR6, SO4 for lateral rectus for the 6th, and then superior oblique for the 4th. So before I move on to something, I want to just say that if you're moving the eye away from the nose, it's a lateral movement, so it's going to be abduction, abduction. So that's another term that they can use. And then if you're moving the eye towards the nose, it's a medial movement, and that's deduction or adduction. So just don't confuse those two words, because they will come up in some pictures sporadically. Oh, okay. So here, if you take the muscle of the eyes, and if we cancel out every single muscle that cranial nerve 3 basically innervates, then your pupils will be dilated, there's ptosis, and they'll be down and out. So that's one way you can remember that. All right, so again, like I said in the previous page, like when you talk about abduction, abduction, it's the lateral movement, and then adduction is the medial movement. So this will help you if you're confused as to where the eye is going, towards what side. All right, so any questions up to now? Okay, so what we're going to talk about next is basically the pupillary light reflex. This picture I found extremely helpful, but what I'm going to do is give you words and then we'll go over the pictures. So if you're shining a light in one eye, technically both your eyes should constrict. So the illuminated eye, which is the one that has the direct light, has a direct response, and the opposite eye has indirect or a consensual response. So the light signals, so when you have the light, your cranial nerve 2 basically right here will take it down and take it to the pretectal nucleus. So this is roughly where the pretectal nucleus is. Once the pretectal nucleus receives a signal, it sends a bilateral signal to the Edinger-Westphal nucleus, which are slightly up above here. And those Edinger-Westphal nucleuses then will send out cranial nerve 3, via the cranial nerve 3 responses to both the eyes. And that's going to give you the direct reflex here on the eye that's you're shining the light to, and indirect response here. So it's going to go through the ciliary ganglion, and then there's a presynaptic and a postsynaptic, but it's all controlled through the ocular motor nerve. So if you are confused about how you can block this, you have two ways that this thing can be affected, and there is an afferent way and an efferent way. So the afferent way is if you have an optic nerve issue, and if you have any sort of lesions on this tract, you will not be able to get a response, in this eye. However, you may still be able to get a response in the other eye because of this crossover here. So the optic tract, since it does cross, you may still get a constriction response on the other side. And then the efferent is if you just have any ocular motor injury and you're not able to receive any sort of responses back, you may not see constriction. And again, it's through the short ciliary nerve to the sphincter papillae. And so any questions about the pupillary reflex for now? Okay, so again, like I said, when you're doing about meiosis, you're going to have a parasympathetic response, your first neuron is your edge-intervescal nucleus to the ciliary ganglion via cranial nerve 3. And your second neuron is your short ciliary nerve to the sphincter papillae muscle. So there's just a little bit difference in that picture in first aid where it doesn't say that the second neuron and where the short ciliary nerve here is through cranial nerve 3, but I have seen that in multiple other places where it says it's through cranial nerve 3. So take it how you like. And then obviously if you have pupillary light reflex, as we just mentioned, light enters the retina, sends a signal via cranial nerve 2 to the pectinal nucleus, pretectal nucleus, in the midbrain, and that activates your bilateral edge-intervescal nucleus, and your pupils constrict bilaterally. So elimination in one eye will result in a bilateral pupillary constriction. Simple. Now, if you have an afferent pupillary defect, again, and that's due to optic nerve damage or several retinal injury, that decreases your bilateral pupillary constriction when the light is basically shined in the affected eye relative to the unaffected eye. And you can use the swinging flashlight test. So that's when you shine light in one eye, you should see bilateral constriction. If you shine light to the other eye, the constriction should remain the same. But if constriction is less or there's dilation, then you have a relative afferent pupillary defect, and that's called a Marcus gun pupil. So this is important. In some questions, you may get an example of a Marcus gun pupil, and that's just because you have an afferent pupillary defect. Okay, so in cranial nerve 3, however, there's multiple things that can happen. And there's a lot of addition in this slide compared to 2017 first aid. So you guys might want to keep that in mind as far as cranial nerve 3 has both motor and parasympathetic components. But the common cause here, this list is actually a lot greater than what it used to be last year. So you can have ischemia, herniation, and a PCA aneurysm, or thrombosis, cavernous sinus thrombosis, that can cause a cranial nerve 3 defect. So now there's something that I learned is called the rule of the pupil, and that's obviously any cranial nerve lesion, it's going to be down and out, as you can see, down and out. But however, if the pupil is dilated, it's a parasympathetic nerves are impacted, and that's usually because the parasympathetic fibers run on the outside of the nerve. So when they're easily compressed through such a posterior communicating artery aneurysm or uncal herniation, so because of these fibers that are running on the outside, when you have an aneurysm, you're going to get a pupillary dilation. So this is when you have absent or diminished pupillary light reflex. So when you shine the light, you're not going to get a constriction as you're supposed to see. So you're going to get a blown pupil and often down and out gaze. So this picture here shows you a blown pupil because they just have the parasympathetic output issue, which is through the cranial nerve 3. However, if you have an absent of a pupillary dilation, that is a suggestive issue of ischemia. So because cranial nerve 3 ischemic nerve damage is common in diabetes patients, so when you have diabetes mellitus, your glucose can be turned into sorbitol. It spares the superficial fibers to the pupil, so that's why you're going to still get your constriction, which is normal, but you'll get the ptosis and down and out gaze in these patients. So remember, cranial nerve 3 defects are multiple. You have a parasympathetic issue or just a normal motor issue. So keep that in mind. Okay, so the trochlear nerve is the next nerve that we're going to talk about. This one is eye movements, but it's the smallest cranial nerve and only innervates the superior oblique muscle. So this usually turns the eye down and in, and it's used when you're reading or going down the stairs. So as you can see here, this is an example of a patient who may have a lesion in their trochlear nerve. So their gaze will be outwards. So what they're going to do is they're going to have diplopia, and their eye starts to tilt outwards, as you can see in this picture, and they're unable to look down or in. So when you're reading or going down the stairs, so as a compensating mechanism, they'll start to tilt their head away from the affected side. So they're tilting their head this way to basically straighten out their pupil or their eye. But the other eye functions normally so it can accommodate to that change. So when they're going down or reading, you'll see them tilting their heads away from the affected side. And that's how you can basically tell that it's a trochlear nerve issue or trochlear palsy. And this is again is at the superior orbital fissure. So this here is what you would see if you have a cranial nerve 4 defect. Your pupil will be upwards and out, because normally it's holding that to go down and out, but when you lose it, it goes up and out. So here, your eye, if you have a cranial nerve 4 damage, your eye moves upwards, particularly with the contralateral gaze, so going down the stairs, and your head will tilt in the opposite direction to compensate. So in a way you can remember is can't see the floor with the 4 damage. Cranial nerve 4 damage, so something you can use. So I'm going to skip 5 real fast and just talk about the abducens nerve, which is your cranial nerve 6. Only innervates the lateral rectus. Again, the cause of lesion can cause diplopia, and you can't laterally move or look out in the affected eye. So an example here is the patient, if you're missing the lateral rectus, their eye will look in, as you can see here. So if you have cranial nerve 6 damage, the affected eye is unable to abduct, and is displaced medially in primary position of gaze. Any questions?
Nope.
Cool. So this slide is actually just taken directly from First Aid 2018, but I just wanted you to know the ways that these muscles are oriented, the right to the left, and we kind of went over all of this in our previous slides, so I'm not going to dwell too much on this one. All right, so we'll move on to our trigeminal nerve. This has sensory and motor functions, and the main sensory is touch, pain, and temperature to the face. It is the largest cranial nerve and has 3 divisions. It has the ophthalmic, which is sensory, and that one is sensory from the forehead to the bridge of the nose. The maxillary nerve, which is sensory, but it's sensation from eyes to upper lip, plus the lateral nose and nasal mucosa and upper teeth. And then the mandibular one is motor and sensory. It's sensory from the ears all the way to the temples, and touch sensation to anterior 2/3 of the tongue. And then it has motor, which is the muscles of mastication. So the ones that close this jaw are your masseter, temporalis, and medial pterygoid, and opens the jaw is your lateral pterygoid. So I think of lowers as lateral, and closing is the other one. And it exits the skull through the ophthalmic branch. The ophthalmic branch comes out of the superior orbital fissure. The maxillary is the foramen and rotundum, and the mandibular one is your foraminal valve. So when you're testing trigeminal nerve, you can do a pinprick or light touch, or you can do a corneal reflex. So that's test the ophthalmic division. You touch the eye with a Q-tip. It's sensed by the one branch of the cranial nerve 5, and it's transmitted to cranial nerve 7 bilaterally, causing you to blink. So keep that in mind when we talk about cranial nerve 7, and basically it's the temporal branch of the facial nerve. And it also has a lacrimation reflex, and cranial nerve 5 and 7 are also involved in that. And cranial nerve 5 is just senses touch and pain. And then cranial nerve 7 produces the tears. So now if you have a palsy, you're going to get a numb face, a weak jaw, and it deviates to the affected side because you have unopposed action of the opposite side. And you can also get trigeminal neuralgia, which is this nerve pain on the face, and it's kind of very severe. It's painful tick, essentially, and you wince because of the tick. And it usually compresses the cranial nerve 5 fibers near the pons. So you get recurrent sharp pains on half of the face, and the treatment for this is obviously carbamazepine. Cranial nerve 7 is your facial nerve. This is motor and sensory, and basically does them has 5 branches, as you see in here: temporal, zygomatic, buccal, marginal, mandibular, and cervical. You can remember it as 10 zebras bit my chin. It's one way I've seen it. And they do motor innervations, muscles of the facial expression, stylohyaloid muscle, posterior belly of the digastric muscle, stapedius muscle of the middle ear, and that's through the second arch. It has parasympathetic innervations and makes things leaky, and has taste sensations to the anterior 2/3 of the tongue. So a test you can do is facial expressions or puff out cheeks. The results of the lesion is basically palsy, loss of the corneal reflex, mostly the motor part, as we've talked about the sensory part in the last slide, or cranial nerve 5, and you lose taste to anterior 2/3 of the tongue, and hyperacusis. Basically, the patient cannot tolerate the sound because of the stapedius paralysis. Sorry, I had a rough day. Basically, this is a tiny muscle, and it just stabilizes the stapedius muscle or stapedius bone in your ear, and it exits the skull through the internal acoustic meatus. So with cranial nerve 7, you can also have facial nerve palsy, and that can result in and the diseases that can cause facial nerve palsy are Lyme's disease, Bell's palsy, herpes simplex, sarcoidosis, AIDS, tumors, multiple other things. When you talk about Bell's palsy, it's basically an idiopathic neuropathy of the cranial nerve 7, has facial paralysis, usually resolves in a week or two, or weeks to months, and thought to be due to HSV1 induced nerve damage. So, as you see in this slide from first aid, it's most common cause of peripheral facial palsy. It develops after HSV reactivation, and the treatments can be corticosteroids and acyclovir. And then most patients will gradually recover function, but then there's other causes such as Lyme's disease, as we talked about, sarcoidosis, tumors, and then diabetes is another one. So with facial nerve lesions, you want to think of upper motor neuron lesions and a lower motor neuron lesion. If you have an upper motor neuron lesion, the lesion location is probably going to be the motor cortex or the connections from the motor cortex to the facial nucleus of the pons. I have a picture, but I just want to go over these words before I show you the picture because it kind of covers half of it. But so the affected side will be contralateral, and the muscles in the facial expression. So think of the lower half of the face. And is the forehead involved? It's usually spared because of the bilateral upper motor neuron innervation and other symptoms. There is none. Now, if you just have strictly a lower motor neuron lesion, it's usually due to the facial nucleus, and it can happen anywhere along cranial nerve 7, and it's going to be ipsilateral, and upper and lower muscles of the facial expression are usually the ones affected, but your forehead will also be affected. And other symptoms include incomplete eye closure, dry eyes, corneal ulcerations, and loss of taste, as you would see with the cranial nerve 7 effect. So here's a picture, and I don't know how to clear these lines, so let me just go back. So here you have base area of the motor cortex as it's controlled here. So your cortical bulbar tract you can have an effect here, but neurons have bilateral innervation. So if it's just strictly an upper motor neuron lesion, it will not affect the forehead because it's innervated from both sides. However, if it's a lower motor neuron lesion, it's going to be the same side, and if it's an upper motor neuron lesion, it's going to be contralateral, so the opposite side. All right, so cranial nerve 8 is your vestibulocochlear nerve. The function is responsible for hearing and balance as a sensory. So the vestibular portion, compensatory eye movements. So if you have a lesion, you're going to get vertigo, nystagmus, or disequilibrium. And the cochlear portion is basically your hearing. And if you have lesions, you get tinnitus or hearing loss. Test, you can do a hearing test, nystagmus test for balance problems. And it exits the skull, internal auditory meatus. Cranial nerve 9, which is your glossopharyngeal nerve. The function are both motor and sensory. So the motor of the stylopharyngeus muscle, which elevates the pharynx, and that's parasympathetic to the pterygoid gland, so it's involved in salivation. And it monitors the carotid sinus and the carotid bodies. So the sinus is blood pressure, and the body is basically your blood chemistry, and also provides taste to the posterior third of the tongue. A test you can do is gag reflex, and it exits the jugular foramen. So if you have a lesion with this nerve, you're going to get a loss of the gag reflex, a loss of the taste posterior 1/3 of the tongue, and you lose the sensation of the upper pharynx or tonsils. But it also has a hemodynamic effect. It basically tricks your body into thinking that you have a low blood pressure. And because there's no sensory information coming in from the glossopharyngeal nerve, it will do is increase your heart rate, vasoconstricts, and increases your blood pressure. So this is kind of important with blood pressure control in our body. Cranial nerve 10, which is your vagus nerve. The function is motor to pharyngeal muscles and larynx, swallowing and speaking, parasympathetic to the heart and GI tract, has a sensory innervation to the pharynx, trachea, and esophagus, provides taste of the epiglottis, talking, coughing, has autonomic systems such as the aortic arch, chemo and baroreceptors. A test you could say is saying ah, which elevates the palate and give you a gag reflex or voice quality, essentially. We'll talk about that in a few minutes. And exits the skull through the jugular foramen. So if you have a lesion, you're going to get hoarseness, dysarthria, dysphagia, and you get a loss of gag reflex, loss of sensation to the pharynx and larynx, and your weak side palate collapses. So on a lesion, you'll see it lower to the other ones. And the uvea will deviate to the opposite side of the vagus nerve lesion. So this one also has a hemodynamic effect. Basically, it's unopposed sympathetic stimulation of the heart, which results in an increased blood pressure because of this aortic arch, chemo and baroreceptors. So the recurrent laryngeal nerve is a branch of the vagus nerve and ascends towards the larynx between the trachea and the esophagus. So the right recurrent laryngeal nerve loops around the right subclavian nerve, and the left recurrent laryngeal nerve loops around the aortic arch. So if you have compressed them, it can cause hoarseness, and this is sometimes caused by dilated left atrium or mitral stenosis. And then aortic dissection, you can also see hoarseness because of the aortic arch. Another thing that you want to keep in mind is vasovagal syncope, and this is the most common cause of syncope. So this is basically triggers due to the vagus nerve, and you increase your parasympathetic outflow via the vagus nerve. So your decrease in heart rate, decrease in blood pressure will lead to fainting. So there are many triggers such as hot weather, prolonged standing pain, or sight of blood. This is like you're seeing in movies where an old lady sees blood and she passes out. It's usually due to the vasovagal syncope. So good way to keep that in mind. Your accessory nerve function is motor innervation. It does the sternocleidomastoid muscle, and your trapezius, which helps with the head turning and shoulder shrugging. The test you can do is turn the head against resistance or shrug the shoulders against resistance. and the results of the lesion will be difficulty turning the head towards the normal side or shoulder drooped on the affected side. And this exits the skull through the jugular foramen as well. And cranial 12, which is your hypoglossal nerve, has motor innervations to the intrinsic tongue muscles, aka tongue movement. A test you can do is stick out your tongue and make sure it's straight. The result of a lesion the tongue will go towards the side of the lesion, so the tongue licks the lesion is a way you can think about that. Exits the skull through the hypoglossal canal. So, real fast, cranial reflexes, as we've talked about, you have your corneal reflex through the V1, and that has an efferent effect on the bilateral facial nerve, the temporal branch. This is where the tears will come. Lacrimation, obviously, again through the V1 and facial nerve. You can do a jaw jerk, which is basically V3 sensory and V3 motor, which is the masseter muscle. Pupillary, as we've talked about, the light reflex with cranial nerve 2, what brings it in, and 3, what causes the constriction. And gag reflex with 9 and 10. And obviously, this is just a review of all the common cranial nerve lesions as listed in first aid. But we've kind of gone over these, so I'm not going to go back and teach it to you again. Any questions about this?
No.
So this picture, honestly, is just a cartoon picture. I like to see this a little bit better than the first picture I showed you because of the other stuff. This one will strictly focus on the specific nerves, and it's a good way to remember it if you get a picture on your test. So if no questions, I have a question for you. A 43-year-old man was admitted to the neurologic services for evaluation of persistent numbness over his left jaw and lower face. MRI reveals a schwannoma, which is compressing a cranial nerve as it exits near the skull. The cranial nerve involved in this case exits the skull through which of the following foramen? All right, so any guesses? Because numbness of the left jaw and lower face.
So we got cranial nerve 7 column, or cranial nerve 7.
8.
Think about sensory and the jaw and lower face.
So 7.
Jugular foramen.
Okay, so the reason it's not 7, the answer is actually A. It's the foramen ovale, and
5.
yeah, so it's the foramen of the trigeminal nerve division, and standing room only. This patient has a schwannoma of the medullary division of the trigeminal nerve, as the nerve exits through the skull through the foramen ovale.
I was thinking neurofibromatosis type 2.
Yeah. So jugular foramen, it's glossopharyngeal, vagus, and spinal accessory nerve. So that wouldn't even be cranial nerve 7. Cranial nerve 7 comes out the internal acoustic meatus. So that's one. And then the maxillary division comes out the rotundum. No cranial nerves exit the spinosum. And the last one, which is the superior orbital fissure, it's 3, 4, and 6. I don't know why it's at 6 plus. Okay, any questions about this one? And one more. 35-year-old woman presents to the ED complaining of right facial weakness and pain behind her right ear since that morning. Neurologic examination confirms complete paralysis of the right side of her face, decreased taste sensation on the right side of her tongue, and increased sensitivity to loud sounds in her right ear. The rest of her neurologic examination is normal. The patient's given a short course of steroids and her facial weakness improved gradually over the next few weeks. In addition to the symptoms described above, which of the following might this patient also develop?
F.
Okay, there's a F. Anybody else?
I agree.
Okay. The answer is F. And the answers are kind of long, but it's basically Bell's palsy and has acute peripheral facial nerve palsy, an unknown cause. So, do I need to explain this one, or are you guys okay? And that is all I got for you guys. Woo!